Um, so, welcome to the interview with Ben Kanter with Vocera. We're going to be talking about situational awareness. A number of interesting papers have been written starting in about 2012 on the impact of non-technical skills have, or the impact that non-technical skills have on patient safety. One of those non-technical skills is situational awareness. Situational awareness is the topic of our discussion today, and joining us, obviously, is Ben. Um, Dr. Ben Kanter is the Chief Medical Information Officer at Vocera. He's a practicing intensivist. From here, he was a practicing intensivist for many years and the past CMIO at Palomar Health. He believes that IT tools used to improve patient care and the caregiver experience are clinical and need to be owned by clinicians. Prior to joining Vocera, Ben was the CMIO at Extension Healthcare and CMO at Vocera Wireless. So what is situational awareness? It's the thoughtful consideration people give to factors about a situation or task that dictate what information they and others need, when they need it, and how to prioritize competing demands. It is a recognized non-technical skill along with teamwork, communications, and managing hierarchical lines of communications. So we'll start with a discussion on situational awareness at the point of care and then get into how messaging and orchestration systems can provide or support this kind of awareness. So my first question, Ben, is how does situational awareness impact patient safety? And can you give us a couple of clinical examples?
Sure. Morning, Tim, and thanks for having me. This should be fun. I think for those that aren't used to the concept of situational awareness, I think of it in the way that we might think of somebody as having street smarts. If you have street smarts, you're aware of your environment, you're aware of what your impact may have on that environment, and then you can sort of extrapolate a little bit into the future. If I do this, what's going to happen next? And that's all part of situational awareness. So it's something that we all are implicitly aware of. Excuse me. Perfect timing. So it's something we're all implicitly aware of, but when you talk about it explicitly, it can go in a lot of different directions. So you were wondering about patient safety. So very simply, from a clinical circumstance, if I get sent, as an example, a message that a patient has a critical potassium level, I need to know something about that patient. I need to have context of that patient. I need access to data. I need to know the actions of others with regard to that patient. What are the orders that exist on that patient? Who's treating that patient? Because otherwise I can't come up with the right judgment, and without the right judgment, I'm not going to make the right decision. So situational awareness provides me with that data, information, experience to treat the patient.
Okay. So what kind of information is needed to be able to create the situational awareness?
I think a lot of people probably have heard the concepts of smart hospital or the real-time health system. The goal there is to take all the data that you've got, transform it into actionable information, and then you learn from watching it in action. Well, that's what it takes from situational awareness. Situational awareness says, if I understand what's going on around the patient, if I know what's happening and I treat the patient in a specific way and I learn from the outcomes, that's going to make me a better clinician. That's going to make me a better organization. That's going to make me a better administrator. And so real-time situational awareness is a key to enabling me to learn, grow, and become more efficient.
Well, besides having access to the information that's needed, it seems that associations and inferences must be made against that data. Um, how are these associations and inferences identified and defined?
Well, it's something as a human being we do automatically, but it's something that a system has to be taught how to do. So if you think about it from a messaging platform standpoint, it's easy to know that there are patients. It's easy to know that there are nurses. It's not as easy to map the nurses to the patients. You then have events. All of those events have to be mapped in the correct manner. Either they're events that are happening geographically or to a patient. So you have to be able to make sense of the environment. So in order to develop real-time situational awareness in a communication system, you've got to embed it somehow with the ability to make some kind of logical sense of the environment that's happening, whether that's administrative or clinical.
Okay. Oh, well, what's the ultimate goal of situational awareness?
Um, think of the chicken who crosses the road. Um, if the chicken has situational awareness of what the road conditions were like, what the traffic patterns were like a week ago, and tries to cross the road now, the outcome may not be very good. So real-time situational awareness says that in order to be maximally effective, in order to avoid getting run over, I need actionable data about what is taking place now. I think
Mhm.
that's the simplest, easiest analogy.
Okay.
It's
Uh,
it's too easy, Tim. It's very easy for hospitals to take their data and export it to a third party for analysis, and then get the reports back in a month and figure out, where they did well, where they went wrong. Um, that's better than not having any data analytics at all, but it's not as good as having it in real time.
well, that's similarly, there's a lot of focus on the EMR and what the EMR can do, and um, even a lot of analytic systems look at claims data, and all of that is retrospective, and not just retrospective, but highly abstracted. There's a lot of data that's generated and viewed by clinicians at the point of care that never makes it into, the big data warehouse, and that becomes a challenge if you're trying to do things real time. Um,
Absolutely.
so, what are the mechanisms for capturing the effectiveness of situational awareness and the resulting actionable information in real time and determining the impact on outcomes?
Yeah, outcome measurements are key. So, as an example, I'll give you one process that we measured at one of our organizations that we were working with. There's a process that's in place at most hospitals where if I, as a physician, order a stat medication, that under certain, if not all circumstances like that, I have to actually notify the nurse. The goal is to shorten the time from me putting the order in the electronic health record to the time of medication administration, since so many diagnoses that we treat are time sensitive. So the question is, if you automate that process, if you provide the nurse with information that I have given an order about this patient and what the circumstances are, if I can do that in real time, does that shorten medication administration? And indeed it does. It shortens the time from ordering to time the patient receives the medication. So that's one way to measure it. So time is usually the most frequently used metric for assessing the impact in these cases.
Okay. Um, what basic capabilities are required to enable situational awareness in a messaging and orchestration system, or as Gartner styles it, a clinical communications and collaboration system?
Let me just digress a little bit and talk about messaging systems. When they first started, there was really no concept of situational awareness or context at all. Most were very transactional. A message would come in, and an alarm system would go off, sometimes to the annoyance of everybody on the unit, because it would be broadcast overhead or out the side of a door, with the hope that somebody would respond. Eventually, we were able to map context, understanding that there is a patient in a room and that patient has a care team. And so if an alarm goes off, we know who the care team members are and we know who is responsible. So that was the first step in the evolution of what we might call the clinical communication collaboration suite. As things evolved, there was an early recognition that for mobile clinicians in particular, if I send you a message and I don't send you context, if I don't send you awareness of what's going on with the patient now, you can't make a judgment, and you either have to go to the patient's bedside, which may be a very good thing, or you have to log on to a computer. But if I want to really enable a quick mobile workflow, as much context about the patient as possible. We now recognize that the next evolution is not only situational awareness of what's happening with the patient, but understanding the awareness of being aware of what's happening with the intended recipients. There could be a team of people that I might want to send a message to. Who is best available now to receive that information? Who would be working at the top of their licensure? Who is otherwise not in the process of other clinical activities that could respond? Because in healthcare, most messages are event-driven. Something has occurred that requires either an update to the care team or information passed on to the care team, and there's usually tasks associated with it. And so for me to simply message someone who is now tied up, for example, in a code blue, that's not going to be very effective. In fact, it could be harmful.
Mm-hmm.
To get back to your original question, what do we have to build into a platform? We have to have rules and logic. It can't be transactional. We have to have some idea of presence of the team, and we have to be able to interface and understand what's happening in the care environment. So interfacing into multiple disparate systems, writing rules and logic around it, understanding context of patient and provider teams, and it's not a simple problem to solve.
Right, right. We've talked about clinical applications for situational awareness, but aren't there also potential applications for situational awareness in operational or procedural activities?
Oh, clearly, absolutely. I immediately turn to clinical because that's my background. But one only has to start to think about other, if you will, time-sensitive events that occur, or efficiency sensitive events that occur in a hospital. So the
Mm.
emergency room bed turnover, throughput of patients, all of that is time sensitive. There are multiple inputs, and being aware that there was a backlog due to a cleaning issue in an ICU bed 3 days ago doesn't help you move patients to the hospital today. So again, a very simple example, and it may seem trite, but there's multiple different systems that have to be brought together and interfaced, and then you have to have the right kind of communications platform to get action.
Do you see the emergency department as sort of one of the initial operational areas that you bring situational awareness to? Or do you sort of look across general opportunities like bed turnover on just a general, med surge floor? Uh,
From my standpoint, I don't think that situational awareness in and of itself is the ultimate goal. I think the ultimate goal is being able to take action, but you can't take the correct action without real-time situational awareness. So for me, it's an attribute of the system. It's not the ultimate goal in and of itself. And so I would hope that actually you're looking globally at the entire enterprise, clinically and operationally, and not just targeting one area. But I think if you're going to have effective communications in healthcare, this concept of situational awareness in real time is critical. It's critical no matter whether you're inside the four walls of the hospital or outside.
it's interesting. The whole concept of messaging used to be just, it's secure texting like you do on your phone, only it's HIPAA compliant. And as as we get more experience with that, it turns out that it's so much more than just sending messages between people, per what I call person-to-person communications. That is very transaction oriented. Whereas what we're enabling with situational awareness is a support. It's almost an automation of workflow to a degree, um, or a supercharging or an enabling of messaging that makes it, as you say, more accurate, more meaningful, more effective, and more timely.
The key word there is workflow. Again, with event-driven communications, which is the primary utility here, event-driven communications have tasks associated with them. Some of them have to be taken right away. Some of them can be triaged to later. Others are just for your information, but they become extremely important in making the right decisions at a later time. So we're talking about workflow. And we may call it a messaging or communication platform. We may call it escalation paths for messaging. The reality is it's workflow. This is all about improving the efficiency of workflows.
I agree with that completely. It's the challenge, I guess, particularly for the buyer, is that of all the different systems that are out there, and I track about 200 messaging systems, um, some of them just do transaction-oriented, person-to-person messaging, and then there are some, a much smaller number, that are really capable in the more sophisticated kind of things like situational awareness and actually being able to address workflow. And it's not obvious um, how those systems with those varying sets of capabilities really divide. And it's not always obvious to the buyer exactly how much of what they really feel they need is just person-to-person messaging versus a true workflow automation capability on top of the messaging.
Yeah, again, I look at these as it's not either or. Now, you can go in and say, okay, from a HIPAA standpoint, I need to put in a secure text messaging solution that's transactional, that allows secure person-to-person messaging. And as you say, I was going to say well over 150 solutions. If there's closer to 200, so be it. The fact of the matter is they provide very little benefit to the clinician. There's no improvement in workflow. There is no benefit for the patient. It is a regulatory check-the-box approach, which really doesn't move the organization to a new level. The fact is, communications have evolved over time, and we can do much more. We can improve and offload a lot of work that physicians used to have to do manually by automating these processes in a full service solution, not just a little pocket of messaging. There's another subtle issue if you just put in a silo transactional messaging solution, and that is that with any given event, there may be multiple types of communication. You may have direct synchronous phone calls. You may have text messages. You may have messages that are passing links to what's happening on the patient's bedside monitor. You may be sending images. At the end of the day, if there was a communication breakdown and you're having to do some sort of forensic analysis of what happened, do you really want to try and piece together, well, this was sent over on that messaging solution. This came from a bed alarm system. This came from the bedside monitoring system. This was a phone call. How do you put that all together, either recreate the event or do the appropriate analytics? So one of the benefits of the evolution is that you now have all of your forms of communication, voice, text, alarms, and alerts being basically clinical decision support messages, though generated by systems, not by people, all on one platform, which gives you one throat to choke from an analytics standpoint. That's important. That's important not just in the kind of forensic analysis I talked about, but also during implementation, because if and when there are problems, when you're putting in smartphones, when you're putting in some kind of sophisticated solution to move your messages around, because smartphones aren't very smart. They're actually pretty dumb. And it takes intelligence and rules behind the scenes to make them smart. When you go to do that analytics, when your nursing staff comes to you and says, Tim, getting too many messages, you need to be able to figure out from who, when, why, and what to do about it.
Right. Um, uh, my colleague and I were at a local hymns chapter meeting, and there was the discussion touched on messaging systems, and I asked a question of a gentleman who is a regional CIO for Providence, and I asked him what messaging system are you, because I know he doesn't have one, because I've got a friend who's a cardiologist there, and he complains all the time about how terrible the paging is because they don't have any kind of messaging system. And he said, "Oh well, we're going to get the messaging system from Epic because we're an Epic shop." And and I asked him about the interstitial communications with healthcare trading partners. That a lot of communications that relates to patient care is not just between people on the unit or in the hospital, but it can also include communications with people at a facility that the patient is going to be discharged to, or a specialist that's outside of the facility, or some drug compounding lab that's going to create some medications once the patient's discharged. And uh, I've seen a lot of hospitals sort of proliferate the messaging solutions they get. So they buy, Tiger Text for their patients, or for their outside physicians who have admitting privileges, and then they get a different system for inside the hospital and all their hospitalists and nurses, and you not only end up with this problem with where do you go to get the analytical data, but you also end up with um, this challenge of system proliferation, and I need to send a message to this person, and now which directory of which messaging system are they going to be on? And I got this message, and which system did I get that on? I need to reply to that, and can get pretty messy pretty quickly. And I asked him about that, and he said, "Well, we hope that at some point messaging becomes like a dial tone for a phone system, and that there's this clean, um, transparent interoperability between messaging systems, so that the users don't really care what PBX or exchange the message goes through. They just send and receive them from their phone or tablet or what have you." And while I think that is a laudable um, goal, a laudable thing to desire, this is healthcare. I don't see that coming anytime soon, and maybe never. Um,
Yeah,
we don't have.
I
Yeah,
just
go ahead.
finished writing a white paper on that topic with our CTO for internal use.
Yeah.
You've identified a major issue, which is I'm at let's say, a regional medical center for many reasons, not just clinical, but for financial reasons. There's a lot of incentives for me to try and include physicians who might not be part of my formal medical staff, clinicians who might refer patients in, who aren't part of Active Directory. I want to include them seamlessly within our communication network. Simultaneously, not only are the number of users who want to message or voice call increasing, you've got the Internet of Healthcare things, the Internet of Medical things, which really has been in existence in hospitals for a long time. But basically, the way I look at it is virtually every system we put in these days has a chip in it that allows it to communicate. It can send alarms, it can send messages. And in many cases, now that the nursing staff have a smartphone, which is really a computer, so, oh yeah, it happens to have telephony capabilities, but it's really a mobile computer, have in their hands. A lot of people think, well, it's great. I can start sending all of this information directly to the nurse. I can bypass the ward clerk. I can bypass folks who used to sort of be that triage, filter, um, intermediary, because there was always a chance that the communication would break down at that level, would get delayed. And so there is this well-meaning intent to send things directly to the nurse, but the fact is that the nurse's environment is chaotic, and nursing workflow is interruptive. We know that before smartphones, nurses were getting interrupted anywhere from 5 to as many times as 20 times a shift from all sorts of areas. And now, with the Internet of Medical things inside the hospital, the potential is significant to literally overwhelm any clinical staff member with transactional messaging. Um, So it's a real issue. I mean, people talk about alarm fatigue. It's really interruption fatigue. Alarms are a subset of interruptions. Um, and so I look at it as interruption fatigue, and it's not just the number of interruptions that nurses get an hour. It's how do you avoid what we would call in the alarm management community an alarm flood. Alarm flood meaning, sort of what it describes, too many alarms in a short period of time to allow somebody to adequately respond. Well, how do you avoid an interrupt flood? You can't avoid an interrupt flood if you have one text messaging for one system, you have another message for alarms and alerts, you have another message for EHR, because all of these systems are not interconnected. They don't have any intelligence. They're transactionally routing. And so if you put in multiple systems, they can all ping the same person at the same time. That is a disaster from an adoption standpoint. That is a disaster from a patient safety standpoint.
Well, that's a great segue to my next question. Because part of the definition of situational awareness is helping clinicians prioritize competing demands. And so, how does the system that's providing the situational awareness help with this prioritization? Does the system actually prioritize messages based on the situational assessment? Or is it left to the user to take these messages that come in with the situational awareness, and then they then prioritize it in their own mind, or some of both?
I think it is both. This is one of my favorite topics, and is really key in understanding workflow. Um, let's start with priority. Priority is usually assigned some kind of static value. This is a high priority message.
Mhm.
Well, it's a high priority message, maybe, but over time that priority may change. It may be a very low priority message now, but 6 hours from now could become high priority. So for me, prioritization has always been inexact. Usually in messaging systems, somebody has the ability to indicate that this is a high, medium, or low priority, but the fact of the matter is that's not true. These priorities change and they're dynamic. And understanding that priorities are dynamic and how you reflect that in an inbox is important. Um, the second then is, where do you get all this information? You mentioned multiple disparate systems. You really need one inbox. You need one place where I'm looking for all of my tasks. I have communication tasks, I have procedural tasks, I have rounding tasks, I have administrative tasks. The priorities and the relative ranking, the triaging of how I do this changes over time. So again, ideally, you have a system that allows that prioritization on a dynamic basis. Then there's also the recipients. We talked about recipient priorities. So if I'm going to send, if you're a nurse, and I tell you that your patient, Mrs. Smith, is having a ventricular fibrillation, and there's a code blue, and you acknowledge, and you're going to that, we now know that you have acknowledged that. I want to do something dynamically with your presence. I don't want to leave you in the escalation for things like pain medications, right?
Mhm.
I need to take you offline until you're done with that critical patient event. So the
Mhm.
system itself can help offload some of the prioritization, and some of it has to be done manually. The system will never know everything that I'm gathering from different inputs. So I think it's a hybrid, but the system can definitely be used to automate a lot of this.
Well, it seems that like most everything in life, situational awareness is not a panacea. It's really all about how it's implemented in a thoughtful way to really be effective. What are some of the key considerations in implementing effective situational awareness?
I'm going to take a step back and say, what are my thoughts about in general about putting in clinical communications that really depends on situational awareness. Um, Something you said at the beginning is absolutely true. These are clinical systems. These are used in the care of patients or in the care of the facilities and the systems that eventually treat patients. So at the heart of all this is clinical. And for that, although they certainly need IT support, they need IT to help implement. These are clinical tools. They need clinical ownership. So in my view, from the earliest discussion that's taking place, it should be IT and clinicians hand in hand, arm around each other, looking for a solution that satisfies the infrastructure needs of the organization, but as well as the clinical needs and the patient's needs. So I think that this is a team approach. I do think that you need clinical ownership for adoption. You can implement with IT, but IT is not going to drive adoption. And by adoption, I mean a lasting use of the tool, even if administration went away, even if the policies and procedures guiding communications went away. At the end of the day, you want your clinicians to say, I'm using this system because this is the best way for me to work. This is the system that I choose because it helps me treat patients efficiently and effectively. And you do that only with clinical leadership.
Again, it's another great segue to my next question. Um,
Well, I'm glad to be
about
helpful.
about how this impacts user adoption. If you've got just a straight transactional messaging system, uh, there can be some benefits to drive adoption, but it would seem to me that this contextual awareness and the workflow automation provides a lot more potential value to people and could be a big impact on driving adoption. Have you seen that?
Yeah, well, there's no question about it. So again, I'll go back to where I've spent most of my last 12 years, 15 years in innovation, which is on mobile workflows. If you drive me back to the desktop, you've broken my workflow. If I'm truly mobile, I want to be able to get information. I want to be able to get situational awareness. I want to be able to get my messages and communicate, and I want to be able to act all from a mobile platform. And so there's tremendous efficiencies if it's done right, and you can create tremendous consternation when you have partial solutions in place. I'll go back to simple transactional text messaging, which I think is an absolute waste of time. You get messages and you don't have context, and you can't make judgment, and you're driven to make a phone call to follow up. You're driven back to a computer to get data. You might as well be using an old style pager.
Mm. Um, have users provided meaningful suggestions in addition for additional or improved situational awareness post implementation?
Yeah, like most IT and other projects, crawl, walk, run is our mantra. Um, Speaking about Vocera in particular, our intelligence layer can, which we call engage. So our engage layer can interface with now close to 150 different hospital systems. Do we want to build workflows around all of those systems on day one? I think not. That would be a silly and an awful experience for the end user. The reality is that there's low-hanging fruit. That there are very high priority, easy integrations that need to be done. And when the team is used to having a smartphone, when the team is used to having workflows and messaging coming straight to them and being able to act on the run and have a sense of what they can tolerate, then you can move on to new and better workflows. So for example, we start with integration to the nurse call systems. You would prefer that a nurse not be bothered about a patient needing water if there's a nurse's aide who could provide that solution. Similarly, why send a nurse's aide a note that the patient needs pain medication when his or her licensure wouldn't permit that? So routing simple information like that is a first step. Routing some of the alarms that may be high priority. So let me give you an example. A good system, well, let me give you the difference between a basic transactional system and a more advanced CC&C, clinical communication collaboration suite, how they would work. So let's say I have a bed vendor, and my smart bed can tell me if the patient's getting out of bed. So it can send an out of bed alarm. Out of bed alarms are very binary. They're either you're getting out of bed or you're not. It's a yes or no. There is one alarm that the bed generates. It's out of bed, out of bed, out of bed. The reality is that there's a patient in that bed, and that patient may be at high risk of falling or at low risk of falling. Those are two very different scenarios. But that information is not something the bed is aware of. That information was documented by the nurse in the electronic health record. That's a different system. A transactional system simply says, aha, there's an out of bed alarm, and sends the message to the nurse saying, patient in bed 317 is trying to get out of bed. That's all the information you get. Or actually, in the old days, it would just, there'd be an alarm that would go off, or a light outside the door. The more advanced system says there is a patient. It is Mrs. Smith. Mrs. Smith has this EHR, and this EHR, she is a low priority. She is a low risk of falling. Ah, okay. So we have a patient who's getting out of bed that's at low risk. Fine. I'm going to send just her nurse a non-interruptive note that Mrs. Smith is getting out of bed. And it may be that she's actually allowed to get out of bed, that she's supposed to ambulate on her own. On the other hand, if Mrs. Smith was a high fall risk, a system like ours can convert that then to a high priority alarm. So it's the same out of bed alarm, but instead of being low impact, low priority one person, we turn it into a high priority alarm and can send it to the entire team if that's how the staff wants it. The goal being, interrupt that patient from falling. Stop, it's all about the patient. So by integrating information from multiple disparate systems and writing rules around it, you can achieve a lot more than what your individual systems on their own could do.
Do you, as customers get more experienced with the system, do you see them making those kinds of additions, writing those rules and configuring those things themselves? Is that part of your implementation where you train the system administrator to be able to do that? Or is that something that you have a program where you come in on a pre-scheduled basis or an as-needed basis to make those kind of optimizations?
Yeah, we very much would like to get to the point where the system is sufficiently configurable that new rules, if you will, new workflows could be implemented. Right now, we do that, and then how we work that out is dependent on how the system was implemented and sold in the first place. So for now, yes, we do. We come in, we help and set up the additional rules, the additional workflows, the additional interfaces. As I mentioned, we already do interfaces to almost every hospital system, and the interfaces that we put in without cost to with our partners. But the workflows, the professional services, right now there is a cost. But we are actually in evaluation of building a more user-friendly interface to the workflow portions.
Excellent. Everybody likes DIY.
Yes, yes.
DIY.
Well, some do and some don't, but you're correct. Yeah, we want to be flexible.
We mentioned how this all impacts patient safety, and I'm curious, as workflows are automated, is there any risk analysis or validation and verification testing done to ensure that the resulting configuration is safe and effective?
Well, many of these configurations have been in the marketplace for many, many years and have been used. And I mean, we're in 25% of U.S. hospitals to one degree or another. We're international, and so a lot of these workflows are extremely routine. Let me give you a workflow that I was proud to be a participant of before joining Vocera, but it illustrates some of what I think you're talking about. At Wake Forest University, this goes back a couple of years now. I was working with them to implement a surveillance monitoring system, real-time physiological monitoring of patients who normally would not receive continuous real-time monitoring. And the question was, if we automated sending the results of the heart rate, blood pressure, respiratory rate, the vital signs to nursing staff in real time directly when thresholds were crossed, without requiring a monitor watcher, without requiring, if you will, a teletech. If we automated the process, what would the outcomes be? And what we found was that zero alarms or alerts were missed. And then you can start to quantify and say that, yes, every time an event happened, the nurse responded 85% of the time, roughly, in less than 2 minutes. And so with these systems, you can begin to audit that. And since the analytics package is really part of the system, you can tell right away whether or not you are achieving the goals that you want.
Okay. Um, does situational awareness trigger messages on its own? Or is this simply a complement to a message that's generated by external events or by users?
Yeah, I tend to use it not as an event, but rather as an attribute of the system. For me, I don't think about it that way. You probably could. There's some fairly academic treatises on what constitutes situational awareness. For me, it's more about how can I continue to evolve our communication platform so that the platform itself is more situationally aware. And I know I'm kind of anthropomorphizing, what is a set of rules and logic, but behind the scenes, that's what our team is working on.
Mhm.
I mean, this street smart element that I referred to at the beginning. How do I
Mhm.
make our messaging platform street smart?
Right. Well, so what's next for situational awareness? Now that we can anticipate needs and provide users with relevant contextual information to provide situational awareness, what's the next step?
Well, it's continuing to evolve. So as I mentioned at the beginning, we now have very good ideas of context of the patient. We're getting better and better with knowing the context of the recipient or recipients and understanding how we can alter their presence dynamically. I think the next step is additional rules, logic, AI techniques, if you will, behind the scenes to look at these activities. How can we better refine them? If I go back to the concept of the alarm flood or the interrupt flood, there's patterns in all of this. There are, I'm sure, more sophisticated ways than the way we're doing it today to look at all of the various inputs and then to dynamically change who's available for what messages. So just as an example, if I have knowledge that you have now received 3 phone calls, 6 text messages, and 2 alarms in the last 5 minutes, which is certainly possible,
Sure.
then perhaps in real time, I should give you a 10-minute breather and send the next low-level prioritization to whoever is backing you up on the escalation tree. Well, we're not doing real-time changes to escalation based on this analytical framework of all of these activities. But I think it's an intriguing approach. There's certain implications as far as how a patient is cared for. It's more of a team-based approach. It's much less about the individual, but team-based care is fairly common. But I think we're a long way from enabling something like that. But I think that's where it needs to go. We know that clinicians have been interrupted for a long time, and that interruptions absolutely can have devastating outcomes that are very problematic, not just for the patient, but burnout is related to interruptions, not being able to get your work done, and having to manage multiple different tasks. I think that over time, these systems will evolve to help and directly improve clinician burnout.
Mhm. I have sort of grabbed onto the term orchestration as the planning or coordination of elements of a situation produce a desired effect. Um, and the formal definition includes the phrase, especially surreptitiously. Now, I'm not implying that we need to do this, on the down low, that people don't know what's going on. But I see surreptitiously in this environment to be something that's more automated, as opposed to requiring the clinician to process a bunch of information and then make a decision. Um, and I don't see orchestration as a replacement for situational awareness. I think of it, maybe it's more just a question of degree. And as you get beyond um, pulling together the situational awareness, the contextual information, and you start leveraging that to a greater and greater degree to automate workflow, even to the point where the system makes a choice, like changing the escalation route that you just described, would be more of an orchestration thing. Or an example I like to use is a system is monitoring the transactions that are going on with a real-time location system that tracks staff and patients, and an OR patient throughput system, and recognizes that a particular resource, maybe it's the anesthesiologist, is not where they're supposed to be at the right time to keep everything on schedule. And so the system doesn't point that out to someone. The system just generates a message to the anesthesiologist reminding them that the case starts at X minutes in room Y, and that we're looking forward to your appearance. Um, so um, I sort of see this as a building on, or a more sophisticated kind of situational awareness, and implies greater automation. Um, do you see this as a potential direction?
Yeah, I love the term orchestration. I've used it myself, and in an orchestra, you've got multiple different groups of musicians playing different instruments, and the sound can be very dissonant without some kind of, if you will, command and control, meaning the music, the sheets, the conductor, but the symphony is the output when it's all matched up and it works beautifully. And I think hospitals are a lot like that. So I like that analogy a lot. The real time is important. I can orchestrate the heck out of that nurse, out of that chicken crossing the road based on traffic patterns. But all it takes is one person driving that I wasn't expecting, and that ends that experience. So from an adoption standpoint, I think it is important to have as much information that's current as possible. And for me, when you start saying, well, is orchestration a place where we might evolve to? I think that's just another way to describe some of the same thoughts that I've been talking about, which is a more dynamically changing rules environment behind the scenes. Instead of having static rules that say that always send a, stat potassium to X person, uh, those rules begin to dynamically change based on what's happening in the environment. It is the next context, if you will. We've gone from context of the patient to context of the recipients. Now it's a self-awareness context. The platform needs to become self-aware. The platform needs to become not self-aware in the AI standpoint, but self-aware from saying, if I've messaged this person multiple times as we talked, what are my options for the next message that comes in? Should I send it to you, or should I not send it to you? What has happened when I've sent it to you in the past? If I've sent you 10 messages in a row, has the 10th message always waited an hour before it's been responded to, or do you get right on it? So,
And that leads to the question of sort of from a technology perspective, machine learning or some other flavor of artificial intelligence. Are these, is a rules engine? Well, obviously, a rules engine is sufficient for doing what we're doing now because we're doing it. And there are some messaging vendors that are making machine learning type claims. Do you see that as an essential technology moving forward? Do you have any thoughts on that?
yeah. So the rules that we have, as advanced as they are, they're certainly sufficient, but are they optimal? And as our rules evolve, as the complexity of our rules engine evolve, then yes, using neural network techniques as an example to look at the patterns, to evaluate the kind of information flow. What about the content of the traffic flow? What does the content of messages say about what's happening on a given care unit or in a hospital or to a given patient. And how is that information potentially of use? Simple example, for those who may be wondering, what the heck is he talking about? If I'm the nurse manager of a unit and I come in the next day, would it be a benefit to know that, yes, there were 37 messages about patient Tim G, but only 2 messages about Ben Kanter overnight? One would think, well, there was, you know, Tim was much more raucous last night than Ben was. Something was different. There's something different there just in the number of messages. But if you have access to content, if content's flowing through your system from, let's say, text messages and other things, what can we glean about what's happening real time in the environment? So there's a lot of opportunities out there, and we're looking at some of these.
Well, one of the big challenges of implementing machine learning or other AI type technologies is having a sufficient um, data set that you can use to train the algorithms. And it's I was I was the program chair for a conference on messaging that you also presented at, and one of the presenters, the CEO of a company in Seattle that does patient engagement, uh, said that they used a data set from Rotten Tomatoes to train to on evaluating movies and
Yes.
reviewing movies, and they use that to train their algorithms for, um, I guess, patients evaluating something similar in their environment. But there seems to be a real market opportunity for large data sets that people can use to train algorithms. And it seems to be a situation too where the established vendors who have customers that are generating a lot of data, provided you guys can get access to it, have a real competitive advantage in moving in that direction because you theoretically have access to a large data set that you can use to do your own algorithm education.
Yeah, to some extent, it depends on which AI techniques you're enabling or you're using, and what your goals are at the end. Um, but yes, we recognize that there is a tremendous amount of data in our system. It's not our data, it's our partners' data. But can we create systems that give them additional information about their data that's flowing through our system? If we have information about all the various forms of communication, text, voice, alarms, alerts, uh, for now, um, there's a lot of information there that we aren't doing anything with, that nobody's really doing anything with. And without getting into specific details, yeah, the volume of data helps us, but it's outcomes. When you're talking about training, most of that's sort of neural net machine learning, and a lot of that has to do with pattern recognition, and you have to know in that circumstance that a cat is a cat if you want to train your computer to find cats in a picture. You've got to have good examples of lots of different cats. So it's the outcome that's key, and you need to focus on that. It's sort of like if you're doing predictive as opposed to detective monitoring. To build your predictive algorithms, you have to have a really good focus on exactly what it is you're trying to predict. And um, it would be the same concept for us. Focus on the outcome.
Right. We're getting close to the top of the hour, so let's close out talking about this from a buyer perspective. Um, what what observations do you have on or advice to buyers that you might have to help them gain an awareness of this um, situational awareness requirement, really, in their adoption of messaging? And while it's something that they're aware, it's the kind of thing, if you mention it to them, it's like, oh yeah, you're right. But it's not necessarily something that they think about when they start going through the process. Because when I
Yeah,
look at RFPs, it's all a bunch of messaging features. and typically doesn't say anything about situational awareness or anything about their own use cases or workflows or anything. So what advice would you have to buyers?
Yeah, it's a very complicated situation now, more so than you might think. And so um, this is not really addressed to somebody in IT that's been told by his or her boss, you need to put in a HIPAA compliant solution because Joint Commission jumped down our throat about our physicians not using secret texting. If you do that, you're really setting your organization up to fail in the long term. You're not going to get adoption. And honestly, you haven't really improved life in your hospital one bit. You may have taken a little bit of heat off your boss, but that's it. The reality is that it is a complex and evolving area. There are people like yourself, as an example, from a consulting standpoint, that have a lot of knowledge. So I do like the RFI process before RFP. If it's not an area that you have internal knowledge of, or even if you do have some internal folks who believe or may have significant knowledge in this area from prior experience or training, understanding what's going on in doing an RFI can be very illuminating. An RFI can give you a lot of this information that may start you thinking in a very different way. It can be very educational. So I like, in that circumstance, an RFI before the RFP process. As you mentioned, RFPs tend to be much more granular, much more in the weeds, much more um, um, feature driven.
Mhm.
And that's unfortunate. I mean, there's certain core features and functionality that you do need to assure that are there, but quite honestly, most people who are writing these don't really know a lot about what they're writing about. They think, in basic terms, and it doesn't always give you a chance to say, yeah, that's fine up to a point, but that's not going to get you where you need to get. I think understanding what are your underlying problems that you're trying to solve. That's where it takes that combination of the clinicians partnered with administration and IT, all at the table together, understanding from the beginning of the project what are the issues we're trying to solve, what are our goals for our organization, um, are we trying to move us to a new place? And for me, um, this is all part of a process that started almost 20 years ago. Hospitals converting systems to digital,
Mhm.
developing reams of data, that most of which was siloed and nobody did anything with. And now more and more hospitals have put in their data warehouses and have data analytics systems. And how do you move that data to become actionable information and learn from it? How do you outcompete the neighboring hospital down the street? How do you improve the care for your patient who is in that bed? Um, and how do you do it quickly and efficiently? Well, these systems help you do that. If you're trying to become a real-time health system, act and most efficiently as possible, if you're trying to really improve the care of your patients, if you try and do that without a CC and C suite, without some kind of intelligence behind the scenes, it's sort of like trying to run a marathon and have a spinal cord injury. There's no communication. The body cannot react in the way that it needs to react. So I look at this as we're the nervous system for the organization. Um, and the more efficient we are, the more effective we are, then the more efficient and effective the organization acts.
Great wrap up, Ben. We're 2 minutes from the top of the hour, and I want to thank you for taking the time to chat with us today. It's been a great discussion, and a good discussion about things that a lot of people are sort of vaguely aware of, but not explicitly aware of, and things that they really need to have a lot more explicit knowledge on. So I
Well,
want to thank you.
I appreciate you giving me a podium to kind of get some of these views and information out there. I think that the more that people understand about this, the better decisions they'll make.
I agree.
Yeah. I don't know if there were any questions by anybody, but I haven't seen any come up.
Well, I saw one come up, and that is, can you give an example of how a workflow can be affected with a messaging system?
Yeah, I think that probably was older, as I think we did
I think we did cover
cover
that
that.
pretty well. Okay, everybody else that's on, here's your chance. Nope, they're too shy.
Looks like we're good. All
All
right.
right, great. Well, thank you. Everybody have a good day, and
My pleasure.
we'll see you next time.
Thanks, Tim. Bye-bye.
Thank you. Bye-bye.